Welcome to the deep dive. Have you ever wondered, what it really takes to operate at the absolute peak of pre-hospital emergency care? Well, today we've sort of got the inside track. Our source material is pretty unique. It's an advanced interview guide for the Advanced Paramedic Practitioner role, or APP, and it specifically maps out the expectations, the standards within the UK ambulance service.
Yeah, and this deep dive, it's a bit different. Our mission isn't just like looking at a job spec. It's more about reverse engineering what mastery looks like in this field. This guide, it really unpacks that complex mix of clinical skills, ethical judgment, and communication that's needed when you're the highest level of care first on scene.
Exactly. We're pulling out the real nuggets here. We want to show you not just the qualifications, that we'll cover those, but how these experts take in loads of information and turn it into, instant life-saving decisions. We'll touch on everything. Advanced trauma stuff right through to handling those tricky psychological curveballs you get in high-pressure situations. So let's maybe start with the foundations, the hard skills. Okay, let's dive in then. What's the biggest hurdle, clinically speaking? How do they prove they're genuinely advanced, not just experienced? What defines that step up?
Right. It really boils down to documented, proven ability. The ability to act independently, manage really complex situations. The absolute foundation, obviously, is HCPC registration. That's the Health and Care Professions Council.
Yeah.
You're licensed to practice, basically. But beyond that, the expectation is specialized training. Postgraduate level stuff.
So specific qualifications that build on the standard paramedic skill set. Is that it?
Absolutely, yeah. Think enhanced skills like advanced ECG interpretation, managing minor injuries perhaps, specific drug protocols, and crucially, the sources hammer home continuous professional development. CPD. It's not just saying you go to workshops. You have to show how you actively review new evidence, how you integrate it, reflect on your practice, constantly improving. Honestly, that commitment, it's pretty much essential just to stay current, let alone advance.
That makes total sense. You need that clear trajectory, moving from following the rules to actually leading the clinical strategy on scene. What examples do the sources give for showing that advanced ability in practice?
Well, the guide really zooms in on advanced airway management. That seems to be a key benchmark. And they don't just ask, do you know how to use the kit? No, they want real hands-on experience descriptions and critical judgment calls. You need to be totally comfortable with standard things like intubation, sure, but also the more complex tools, supraglottic devices, for instance.
Okay, give us the nugget then. Where does that advanced decision-making really show itself?
It shows when things go wrong, when the standard approach fails. The scenario you have to be prepared for, mentally and practically, is the can't intubate, can't oxygenate situation. CICO, they call it. That's where maybe in a really bad trauma case, say major facial injuries, you might have to make the split-second decision to go for a surgical airway, like a cricothyroidotomy. The ability to calmly see the anatomical problem, realize standard methods won't work, execute a procedure you might rarely do, but which is life-saving, and then manage the fallout, the complications. That's what sets the APP apart. It's pulling together procedural skill, rapid assessment, and risk management all at once.
Wow, okay. That sounds incredibly intense. So if that's the single patient high-stakes scenario, how do you take that same level of thinking and apply it when it's just utter chaos, like multi-patient incidents? Prioritization must be key.
Oh, absolutely. Moving from one critical patient to a multi-casualty incident, an MCI, that's where the APP really earns their stripes, their command presence. The sources lay out a strategy, and it's all about speed. Rapid assessment, using triage tools, based on symptoms, vital signs to instantly gauge severity.
And it's not just about treating individuals then, is it? It's managing the whole scene, the crew.
Exactly that, yes.
Yeah.
Stabilizing the most critical first, obviously. But the real skill is in the coordination, the communication.
Yeah.
You have to delegate clearly, efficiently. The example given was coordinating the crew at a multi-vehicle crash. You're making sure that while the immediate life threats are being managed, maybe less obvious injuries aren't missed, and that resources back up, special teams are called in and used effectively across the whole scene.
So the APP is that central mind making the fast call. What's that process like when someone starts deteriorating rapidly in front of you?
It's described as a quick, calculated balancing act. Risks versus rewards, basically. You assess fast, you spot subtle signs maybe, the early warnings of deterioration, and you intervene, swiftly, preemptively almost, before it spirals. A classic example they gave was recognizing that textbook severe chest pain, thinking possible heart attack, MI.
Okay, but what's the advanced part there? I mean, most responders know chest pain is bad news.
The advanced piece is maybe administering more specialized, potent medications, fibrinolytics perhaps, if it's within protocol, or managing tricky fluid resuscitation. And doing that while simultaneously sorting out urgent priority transport, getting them moving. It's that blend of intervening at a higher clinical level and managing the logistics to get the patient stabilized and to definitive care faster. That's the edge.
Right. But not every call is a straightforward heart attack, is it? What about those really complex cases, the confusing symptoms, unusual presentations that just don't fit the standard protocols?
Ah, yeah. This is where reflective practice comes in big time. When the picture's muddy, the steps outlined are pause, breathe, calmly reassess the history. Maybe liaise with other specialists like an on-call doctor, get another perspective. This allows you to tailor treatment, think outside the usual boxes. There's a good example in the sources, actually, managing someone with really confusing, non-specific symptoms. And through careful assessment, differential diagnosis in the field, maybe talking it through, they actually avoided an unnecessary trip to hospital, which is better for the patient and the system.
This all sounds like it relies heavily on being absolutely up to date. You can't just rely on training from years ago. How do the sources say APPs keep their clinical knowledge sharp?
The expectation is definitely active engagement, evidence-based practice. It means regularly reviewing and actually reflecting on trusted UK sources, like JRC LAC, that's the Joint Royal College's Ambulance Liaison Committee guidelines, they're kind of the Bible, and LICE updates too, the National Institute for Health and Care Excellence. You have to show how you actually change what you do based on new evidence. Like maybe demonstrating you adjusted how you assess for sepsis after recent guidelines came out because you saw proof it could improve outcomes. It's about acting on the knowledge.
Okay, so moving away from the pure clinical stuff into the psychology of it all. It sounds like managing people, patients, families, colleagues, especially when emotions are sky high, is almost as critical as managing their blood pressure.
Oh, it absolutely is. Communication is just paramount. You've got seconds, literally seconds sometimes, to build trust. And the guide highlights things like active listening, really paying attention, empathetic body language, communicating clearly, calmly. The example given, simple but effective, was warmly introducing yourself to a distressed elderly patient. It seems basic, but it breaks down barriers instantly, helps you get that vital history.
And what about when standard talking doesn't work? You know, those really challenging situations, distressed patients, nonverbal, maybe even aggressive ones.
Yeah, then the focus shifts, doesn't it? It becomes all about nonverbal cues. And patience, so much patience. You have to stay calm yourself. Use clear, open body language, gentle eye contact if appropriate, and just adapt your style. With someone nonverbal, maybe it's using simple pictures or just encouraging nods, simple gestures to check understanding of basic needs. The absolute goal is making sure they feel safe, respected, even when communication is really difficult.
Okay. And talking to colleagues, professional communication. Patient handover feels like such a critical point for safety.
It is. Huge potential for error there. So the handover protocol needs real discipline, clarity. The APP needs to give a concise, structured summary, often using a system like SBR, situation, background, assessment, recommendation. You've probably heard of it. And just as important is actively listening to the team taking over, answering their questions properly, maintaining respect, cooperation. It's all about creating that shared picture of the patient's needs moving forward. Facts, not friction.
Right. Now, the really tough stuff, ethics. How do you possibly balance that professional duty, to save a life with respecting a patient's right to choose their autonomy?
This is absolutely core APP territory. You have to show empathy, rock-solid professionalism, and stick rigidly to ethical and legal standards. Think about that really high-stakes example, a patient who seems perfectly able to make decisions but is refusing hospital transport, even though they have serious, maybe life-threatening symptoms.
That's got to be incredibly difficult. What's the expected advanced response there?
The key isn't trying to bully them into going. It's about the process. First, you have to be sure they do have the capacity to make that informed choice. That's a skill in itself. Then you calmly, clearly explain the risks, the potential consequences of refusing, and the crucial advance bit, exhaustive documentation. Recording the conversation, the capacity assessment, the risks explained, everything. It protects the patient's rights, but also manages your own professional risk. It underlines that respecting an informed choice, even when you disagree with medically, is part of the duty.
And that essential duty of safeguarding, when you suspect abuse or neglect.
Yeah, that starts with just careful observation, non-judgmental observation, looking for signs that don't quite add up, maybe injuries that don't match the story, odd behaviors. Then gently exploring concerns, trying to maintain trust, And then critically, following local protocols immediately. That always involves collaboration. Social services, maybe police, other professionals. It's a defined pathway, really, to make sure vulnerable people are protected.
Okay, one last one in this area. Team conflict. In the heat of the moment, disagreements happen, but the patient has to come first.
That's good. The APP often has to be the mediator, the calm voice. Conflict resolution here means actively listening, understanding why there's a disagreement. Is it a misunderstanding about a drug dose? Miscommunication during handover? The decision on how to proceed has to be based on objective stuff. Evidence, guidelines like JRCLC, and what the patient needs right now. The aim is to foster open talk, find common ground quickly, reach a collaborative decision. Proving patient safety trumps any personal disagreement every time.
So, okay, we've established this role needs, like clinical perfection and this incredible human mastery. But even the best clinicians still have to get through the job interview, right? The standard questions. What are the common ones people should prep for to kind of summarize maybe a decade or more of intense experience?
Yeah, you absolutely need to craft your story, distill your career into powerful examples. So why should we hire you? The focus has got to be on solid, quantifiable experience, mentioning, strong background in emergency or critical care, 10+ years maybe, high-quality care focus, dedication to ongoing training. For strengths, the sources suggest things like ability to stay calm under extreme pressure, obviously, strong communication skills, and meticulous attention to detail.
And the handling pressure question, I mean, that is the job description, essentially.
Exactly. And the guide suggests framing your answer around a defined process, how you stay focused on the patient's needs, how you rely on your training almost instinctively, how effective communication with the team helps manage stress, and crucially, using debriefing and reflection afterwards, processing it, learning from it. That's key.
Right. Now, for the fun part, maybe, the curveball questions, these aren't about clinical knowledge at all, are they? They seem designed to test self-awareness, maybe abstract thinking, how you prioritize things outside the immediate job.
Yeah, these are great. They really can reveal character, can't they? Like, if you could have dinner with any historical figure. The suggested answer was Ada Lovelace. And the reasoning, she wasn't just foundational in computing, she had this incredible foresight, vision. So choosing her suggests you value innovation, thinking ahead, groundbreaking ideas, all good traits for advancing clinical practice.
That's clever. Okay, how about the superpower question? What does that reveal?
They want to see something pragmatic, relevant. The suggested power was instant healing. It shows, direct relevance to the job, a desire to fix the core problem immediately. Plus, empathy. It's a pretty safe answer, actually, but very job-focused. Shows dedication.
And the classic desert island question, 3 items. Pure prioritization test, yeah.
Totally. And the suggested answers show sophisticated planning for survival, not just, comfort. So, a solar-powered water purifier addresses the most basic need, water. A multi-tool for problem-solving, shelter, general usefulness. And a waterproof notebook and pen for planning, tracking, maybe just staying sane. It shows you understand survival hierarchy. Needs versus wants.
Okay, nearly there. Crucial prep tips for anyone listening who's aiming for this. Where should they be looking for info about the specific ambulance trust or organization?
Right, you have to do your homework. Show you're serious and aligned with them. The trust's website is your first stop. Mission statement, values, news, blogs, see how you fit. Social media, especially LinkedIn, maybe can give you a feel for the culture, initiatives, maybe even the structure. And yeah, check online reviews, Glassdoor, places like that. Look for themes, but, take individual comments with a pinch of salt.
And keeping up with the wider industry news.
Oh, vital. Set up Google alerts for the trust, maybe key people. And keep reviewing JRCLC and NICE regularly, showing you're proactive, that you know the current debates and updates. It tells the interviewer your commitment goes way beyond just the interview day.
Makes sense. One last practical point, looking the part. Presentation. What does the guide suggest for interview day itself?
Keep it professional, polished, competent. Smart casual is the advice. Avoid anything too bright or distracting. Clean, well-pressed clothes. Comfortable but smart shoes you might be walking around. Minimal jewelry or accessories. And, really important, impeccable personal hygiene. Avoid strong perfumes or aftershaves. It's a healthcare setting after all. Keep it neutral and professional. #tag outro.
So we started looking at an interview guide, didn't we? And we've kind of ended up with a blueprint for real high-stakes professional excellence, the Advanced Paramedic Practitioner role. It really is defined by that incredible balance, isn't it? That blend of technical skill, unwavering ethics, and exceptional communication, especially under pressure.
Yeah, what really stands out for me is that genuine advancement in medicine like this. It isn't just about knowing some incredibly rare procedure. It's about consistently nailing the basics: safe drug administration, rapid, accurate assessment, and handling profound human complexity. Things like managing treatment refusal or dealing with severe trauma, grief, doing all that with composure. That combination is incredibly difficult and rare.
So the final takeaway for you, listening. Think about that question from the guide. What's the biggest lesson you learned from your most challenging case? Because the true measure of an expert, it seems, isn't just success, it's that capacity for honest reflection, for continuous improvement.
Right. You now have a sense of the critical thinking needed to, say, stabilize someone in that chaotic multi-vehicle crash we talked about, and soft skills needed to navigate a team disagreement about handover while respecting patient autonomy. So here's a thought to leave you with. Which of those two skills, mastering the complex clinical procedure or mastering human complexity and communication, which one do you think is actually harder to teach?